Hello, everybody. Happy Friday. Thank you for attending the RHC Billing 301 session. This is gonna be an exciting session about filling out the UB04, what all those field locators are, and then probably one of the hardest things and most complex things in RHC billing is how to do secondary billing, and we probably can't do it justice in the amount of time we have. It's probably a 1 or 2 day seminar, but Douglas Ward's from Azalea Health, who's sponsoring this session today, will be going over that with you guys. So thank you for taking a part of your Friday to attend this session. Here is my contact information. I am Mark Lynn from Healthcare Business Specialist in Chattanooga, and Danny Gilbert is here with us as well. She will be taking the questions and will be helping us out with technical stuff as we go through the webinar. What Healthcare Business Specialist does is we prepare Medicare cost reports, which we're doing those as we speak. We are doing RHC cost reports this morning, both Danny and I. We do startups for new RHCs if you want to become an RHC or add a location. We do a lot of emergency preparedness if you get that horrible inspection and you haven't done anything on emergency preparedness in 4 years. We're there to help you with that. And then Danny does the TennCare quarterly reports if you're in Tennessee and need those done. If you probably are here because of the Facebook group. If you've not joined the Facebook group, we have 3,500 members. And there's a lot of people ask questions and we'll answer their questions, and everybody works together in this little community that we have throughout the country. If you do have questions, please type those in on the side there. We will not be opening up the lines to ask questions. It ends up turning into bad radio every time we do that. So what we will do though is if you'll type in your questions, we will try to answer as many as we can in our allotted time. I will take those questions, and we're trying to build our advanced session around those questions. So do ask those questions even if we don't have time. Everything is up to date as of today. We will only be covering Medicare, and Doug will only be covering Medicare because each state is different. You have to have 50, there's 50 different states, and in each state, there's probably 4 or 5 different MCOs in there as well. And so we'll do that. Where to find the slides? These will be, they're not on here right at this moment, but your slide presentation, we will put that on there on our website at ruralhealthclinic.com/RHC webinars. There will be a recording of it as well. So this is being recorded, and we will put that recording on there. There's a YouTube channel. If you want to subscribe and like, please do so. I'm going to be the next YouTube star, apparently. No, I don't want to see just one YouTube check is what I'm looking for. TikTok. Also, I've never seen one, so I'd like to see what one looks like. But one thing too, then this is a little secret between me and you guys, is I did put together a template. It's an edible word, edible. You probably want to eat it. Edible word. I'm going to get this right. A word edible template on grant management policy is on this website here. I put it on there, and if you'll go there, you can edit that and use that for your grant management policy. So we're just sort of that's just between me and you, because I know we got other people out there selling it, and they probably don't want me doing that, but I'm going to put that out there for you guys. Okay. Next week, we're going to have the 401 session. Charles James with North American will be doing that. And Doug, you're welcome to join us for that as a panelist and help us with all these advanced subjects. We'll also be doing one on PRF reporting with Kraft Brothers. And Danny will be doing one of these lunch and learns on TennCare. If you're from Tennessee, you'll definitely want to watch this one on TennCare quarterly reporting. And we just added this one. I added it this morning. Joe Lampard, a good friend of mine from a long time with HIPSA Acuum. 40% of the designations are going to be withdrawn as far as being HIPSA, as far as being eligible for RHCs in the near future. So Joe's going to give us an update on what that means to our rural health clinics and maybe how to avoid this as well. So that's coming up. And then Azalea Health, again, they are our sponsor here. Doug is our speaker today. Doug Schwartz with Azalea Health. He is the co-founder of Azalea Health, and he's vice president of revenue cycle management with them. He's been a friend to RHCs for a long time, and we've worked with him on several other webinars, and we do have an agreement to help with Azalea, and Azalea helps us do things as well. So I'm proud to call them a partner of Healthcare Business Specialists. And Doug, I am going to make you the presenter, so you're going to have control of everything. And thank you for doing this, and I'm excited to hear what you have to say.
Great. Well, let's see. Thank you for having me. Let me make sure you can see my screen. Can you see it?
I can.
You can?
I can see it. Yes. It looks
All right.
so small, but I see a lot of your emails and everything. So I'm not sure if there's a way for you to maximize it, but.
Here we go. How about that?
Perfect.
Didn't realize it was going to do that. All right. So thank you for having me, Mark. My name is Doug Swords. I am with Azalea Health. I'm the Vice President of Revenue Cycle Management. And I'm going to be talking about UBO4 billing today and MSP. I'm actually from the Atlanta area, but I actually call Valdosta, Georgia home. That's where we started Azalea Health. I came down to Valdosta in 1999 to go to college at Valdosta State. That's where I graduated from. That's where I met Baha Zidan, the CEO of Azalea Health, and we started it back in 2008. We focus on electronic health record systems and revenue cycle management. I invited Helen Williams to join me because some of this stuff she knows better than I do. And I don't know, Helen, if you're on, if you could speak. If not, I want to at least give her credit for helping me fill out some of the materials on this presentation. But Helen is our senior strategic healthcare consultant, and she's been working with critical access hospitals and rural health clinics for 25, 30 years. So what we do at Azalea, I'll just give myself a brief plug if that's okay. We do professional services. We have our own software, and we also do revenue cycle management. So we're not like Athena, and you don't have to use our revenue cycle management services. You could just use our software, and the software does work for both independent and provider-based rural health clinics. I remember starting out in 2008, we started the company in Valdosta, and that's where we really started interacting with and learning what rural health clinics were. And my first experience with the UBO4 for a rural health clinic was for an independent rural health clinic in Florida that was using Metasoft at the time. And so at that time we were mapping, we had a print image file. For any of you guys been around long enough, this is before we even sent the 837 files on a UB. We had worked with the clearinghouse to map a print image file, and then they would convert it to the 837 for us. So I remember going through all the boxes on the claim form and making sure that they were filled out and defaulted. And that was a long time ago, but some of it's changed since then, but a lot of it is the same, fortunately. A little bit more about us. I mentioned Valdosta. We do have our head office in Atlanta, but we do, our billing staff is still located mainly in Valdosta. We do bill for multiple different specialties, but as an organization, we do have over 200 rural health clinics using our software, and about 40 or so that we actually do the revenue cycle for. We do value coding certifications, and some of our coders and billers are even rural health clinic coding and billing specialists through the RHC. And we're very heavily focused on performance and being able to perform high levels of different KPIs and benchmarking. So let's dive right in, because there's a lot to cover with the UBO4 and Medicare secondary payer. I'm going to break this down by the fields and walk through it and give you some kind of advice. And a lot of this has to do with like structuring not just the UB, but your electronic claim, making sure that your software is configured appropriately to put the fields in the right places, because that can be difficult at times, especially if you're new. And so we were talking about that before. There's more and more independent provider-based RHCs coming online than kind of I can even remember. And I know one of the biggest headaches with that is making sure your claims are filled out appropriately when you're starting out and learning all that for the first time. Because not only do you need to learn like what goes on the UB, but you need to know where in your software does it go, electronic claim, clearinghouse, and we're not going to go through all that here, but I will kind of throw that in as we discuss the different fields and what they're used for. A couple of resources that are really helpful. The first one in particular is the Medicare Claims Processing Manual for the Rural Health Clinics. That is the Bible for this kind of stuff. So you want to bookmark that and make sure that you have it handy. You have to kind of read through it because if there's a lot of federally qualified health clinic stuff mixed in there, and sometimes you'll read it and you go, okay, that's how you do it. Oh, wait a minute, that's for FQHCs. So make sure that you pay attention to that. And then if you go to your MACs, they often will have really helpful billing guides for rural health clinics as well. Noridian in particular has a really helpful, and I actually pulled some information from there for this presentation because the way they describe like condition codes, occurrence codes for RHCs was very helpful. And Novitas has, I use that to kind of hand type in. So if you wanted to just pull up a UB, if you're in a pinch and you wanted to like hand type one, fill one in, there is a typable UB claim sample from Novitas, and I just put the link in there. Mark mentioned this, and I'll reiterate it. If what we talk about today is going to be Medicare guidelines, Medicaid, as you guys know, is going to be different state by state. I would recommend that similar to pulling the Medicare Claims Processing Manual, you go and find the equivalent from your state's manual. I put Georgia on here because I'm familiar with Georgia. And there's a link. They have their manual on the website. You don't even have to have a login to get to that. But every state is going to be different, so it's going to be too confusing to try to cover all of the above. So today it's just going to be Medicare. So let's start with the first. The first fields are the address fields, but I think those are pretty straightforward. You got the facility and the billing entity. Once you get to field 4, you've got your bill types. So the default is going to be 0711. Do not forget the leading 0. So that is just like from the beginning. If you, I don't know why the leading 0 is there. It actually explains it kind of right there. The digits, the CMS ignores it. But you got to have the 0. One of the first big mistakes that I often see when clients are setting up their databases is they just put in the 711. They don't put the 0 in there, or maybe they're importing from a spreadsheet and the leading 0 gets chopped off. So be careful about that. The other ones that are kind of most used for rural health clinics, the 0710 is not used that often that I'm aware of for rural health clinics, but you will use the 0717 and the 718 from time to time. The adjustment is like your corrected claim, and the cancel is like your void. So those will be, I would definitely set up your default to be 711 because that's the one you're going to use 99% of the time. So, all right, I know it's Friday, and you guys, and I appreciate Mark for letting me do this on Friday. We normally wanted to do it on a Thursday. I'll try to keep you guys awake, but I do want to go through each field on the UB and talk about it a little bit, whether it's required or not. This information is on the Rural Health Clinic, the Claims Processing Manual for Rural Health Clinics. It kind of sticks to the fields that are specific to rural health clinics. There are other fields that are required that you may have to go to the normal Medicare Claims Processing Manual to get more details on those. But I basically cobbled that together, and Mark has, done these same presentations over the years, going back to like 2020, I think I found one, 2018. So most of that has not changed. Some of it is a little different, so here's the basics. What's the field number? Is it required? In a couple of tips. So the first one is the tax ID. A common one here, and we talk about enrollments. If you are a new rural health clinic, you're independent, or if you just converted your hospital outpatient clinic to a rural health clinic, you have to fill out your EDI enrollments, and that those enrollments, the tax ID that you use on the claim and those enrollments must match. That's first and foremost. So if it's the hospital tax ID, or if you have set up a separate tax ID, which I've seen both, just make sure that you've got that taken care of in your system. In that also the statement period. I have seen accidentally where folks don't realize that usually with a rural health clinic, you're dealing with a single date of service and not like a inpatient stay where there's a admit and discharge. So I would see sometimes where they were not filling out the from and to dates, but you have to put them both in, and it's this date of service for both. So make sure that that's being done. The patient name obviously has to match the card. That's true for non-rural health clinic claims as well. So if you do have a mismatched rejection of some kind, you might want to check that out. The rest is pretty straightforward. Some of these, like 14 and 15, are required, and there are a couple of different options, although for your priority admission, a priority type of admission, 3 is the most common. So if you are going to be setting up defaults in your system, I would set that one as your default. And same thing with the point of origin for admission is non-healthcare point of origin, meaning they came from home, they weren't transferred from a skilled nursing facility. Now you do have to be wary of the other ones because you may use them from time to time, but the ones I have kind of underlined are your most common. Another form that is required towards the top of the UB is the discharge to. Most of your rural health clinic patients or when they leave, they go home. But if they are somehow going back to a skilled nursing facility or custodial care facility, you would want to use one of those other discharge codes. I would default it to 1 because that's going to cover the vast majority of your claims. You have your condition codes. Those are rarely used. That's an MSP situation. So I'm not going to cover it here. We will talk about Medicare secondary payer at the second half, but I will mention if any of these fields are used for Medicare secondary payer situations, and this is one of them. But on a normal primary claim that you're sending for a rural health clinic, you are not using that, and it's not required. Same with 29 and 30. So for condition codes, I wanted to point out a couple of resources. Palmetto, who services Georgia, has their listing, and I found this is actually from 2018, so I don't know if using the D9 is actually going to cause your claim to suspend, but I copied that and pasted it. They give you kind of a listing of their condition codes on their website, and there's a link at the bottom. But then I also liked what I saw on the Noridian website. They give you actually more details for their condition codes and when to use them. So this is very helpful. Now, some of this is, as you can see, for like PPS hospitals and things like that, but I do think that it's helpful to have this information handy. It was a little bit more information than what Palmetto gave. So you have again, the occurrence code and date. So if you have a code, you have to have the date that goes with it. It's not required on most rural health clinic claims. It is situational unless you are doing a Medicare secondary payer. And I do have like an example that I'll be able to show you later of an MSP claim filled out on a UB with some of these fields filled in. Then 35 to 36 is your occurrence span codes. We're generally not using those at all. This table at the bottom comes from CGS, which is a MAC that has also some good information on their website about Medicare secondary payers in particular. So I'm a little bit jumping the gun here, but I did want to throw that in because it does relate to the UB, what they have there on their website for that. So 39 through 41, they're not required. These are your value codes and amounts. Again, situational MSP. I put, again, table from the CGS website. That's kind of helpful with that. This is a lot of the information about who the primary payer is, what program you might be in that might be triggering an MSP situation. And those are the fields there. A lot of your software program will also have these pre-programmed in for the most part. So a lot of times if you're clicking around in your software, you should be presented with a drop down too. Sometimes you'll just see the number, and sometimes you'll see the number with the definition. So now we're at the revenue code section, the meat in the middle of the claim form. You've got, it's field 42. The most common one is going to be your clinic visits, and it's 0521, but these are all revenue codes that could be used depending on the situation or location. So Behavioral health is one that's 0900. The last one is it's for show on the claim form, and it's where you have all of the charges totaled up at the bottom. Again, leading zero has to be there. So for this, when you are loading, whether it's Charge Master or if you're using an ambulatory system and you're loading your fee schedule, I know I will see a lot of those be imported through like a CSV or an Excel file, and a lot of times those leading zeros get cut off when they're being imported. And if you don't watch it, you will have a rejection, or maybe your software may catch it. Sometimes it gets to the clearinghouse and that zero won't be there. So these fields, you've got 43 is the description. You have to put clinic visit in there, or that's like a basic description for the 0521. That should pull from your fee schedule Charge Master. You used to not have to put the code in for 44, and I believe now you do. The service date is obviously required. It's the same as that it's in field 6. Units should always be 1. This is, different from your fee for service claims where you could have multiple units on a single line item. This should be only 1 visit billed per day, unless the patient leaves and later returns with a different illness or injury on the same day. I'll point out, I know I said I wouldn't talk about Medicaid, but I have seen with 43 having to put drug code information. Your national drug code sometimes goes in there for some of your Medicaid claims. So 47 is your total charges. It is required, obviously. Your software system should be able to handle that for you. 48, 49, not used, if at all, or rarely, you skip it. And then 50 is the payer name. The payer name is going to pull it as it appears in your software program. The health plan ID is typically the payer ID. And if you're sending your claims through a clearinghouse, it's a 5-digit number assigned by the clearinghouse to send it to. And so if that's missing, or actually one mistake that I do see here with this one is, and we have a clearinghouse, they have, and some payers like Medicare will have a Part A payer ID and then a Part B, or like a UB institutional payer ID and a 1500 payer ID. And a lot of times when we see databases get filled out for the first time and they're loading all their insurance plans, they don't differentiate the institutional versus the professional payer IDs. And if field 51 is pulling your professional payer IDs, it will cause a rejection. So the other two are release of and assignment of benefits. Those are generally set to Y. No need to spend a lot of time on that. If you're sending the initial claim, the prior payments field will be left blank. But if it's an MSP secondary claim, you may have information there. Same thing with 55. 56 is the MPI of the billing provider, which is not the same as the MPI of the hospital. So sometimes that is a mistake that we'll see. The hospital's acute hospital MPI ends up in that field and not the one assigned to the rural health clinic. So be wary of that. Sometimes you may need to put like a legacy provider ID at 57 for Medicaid secondaries. I don't think that's required as much, but it's something to be aware of. You have your insured's name, which is pretty obvious, and then the relationship, which is normally 18 for self. It's almost always 18, but if you wanted to see what the other ones were, CGS again has a great kind of listing here, so you can, and this will probably be preloaded in your software too. So we're getting close to the end of the UB fields. One thing that is helpful is when you're looking at the UB for the first time, it is very overwhelming, but most of those fields you're not actually going to use for the rural health clinic. Most of them, as you can see, are not required. There are just a few that are dependent upon if it's a secondary claim, or like maybe you're filing a corrected claim where you may need to use, but for the most part, these are pretty straightforward. There are just a few hangups, like I mentioned, that if you don't get them right, you could end up with some denied claims or claims that get rejected or in suspend status. So box 60, that's the Medicare beneficiary identifier. We need to make sure that matches what's on the card. Let's see, any of these none of these are required. The document control number, there's a treatment authorization code. That one, not necessarily for Medicare, but if you have like an HMO or a PPO claim where you have a prior auth, you may need it for that, but not Medicare. The group number, again, it might be necessary for a crossover to Medicaid, but probably not. And the document control number is situational. Sometimes when you are doing an adjustment, so like a corrected claim, you will put the claim number in the document control number field when you're refiling a corrected claim. Employer name, not required. Did you get your diagnosis code? In 66. That's your ICD-10 code, and the identifier is 0. So if you are, that's the qualifier, and then the code itself. So if you're sending them, like back in the day when we were transitioning between ICD-9 and ICD-10, you had to make sure the qualifier was a 9 for ICD-9 codes or a 0 for ICD-10. And then the actual ICD-10 codes go in 67. Most of the time, B codes are not appropriate as the primary code. Sometimes they are. Admission diagnosis is not required, not needed for outpatient. Same with the reason diagnosis. Most of these are not used. So lucky us. So 76 is where the provider intending. So sometimes you need legacy IDs, but for the most part, it's the MPI. That's all you need there. We'll put other providers. Sometimes you'll see like a referring provider in there. It's not required. But every now and then you'll see like a referring provider show up on that in one of those other provider fields. And I think sometimes you have to put like a special qualifier, like a DN or something like that, to indicate what type of provider it is. And 80 is not required, but as you can see, it's only needed if you have additional information that you need to send the payer. If the claim is adjusted, canceled, or if there's 2 visits on the same day, you would need to use this field. 81CC, 81CCB. As you can see, this is really not required. Sometimes we'll see the taxonomy code end up in here. And that is the taxonomy code you would want to use for Rural Health Clinic. I think I've seen that a lot on Medicaid Advantage plans or Medicaid CMOs, if you will. They want the taxonomy field in there, but I don't think it's required for Medicare. So I mentioned earlier, you got your corrected claims. So if you do need to do a corrected claim and say it's in an RTP status, you do need to send clean claim. If it's in a suspended status, do not rebill until it is RTP or rejected, then send a clean claim. If it's denied, you need to rebill it as a corrected claim, and that's the 0717 that we talked about is the adjustment. You need to have a condition code in the original claim number. So that's the document control field that I mentioned earlier, needs to be there. I know sometimes if you are hospital owned, you probably have access to DDE and you can handle some of this through that system. You can handle this without DDE, though. You don't need to feel obligated to use it unless you're very I know a lot of people are very comfortable with it, they're handy with it. We are able usually to, with the RCM that we provide, able to handle this just by using these fields for the bill type, condition code, make sure all that's filled out correctly, and resend it back to the clearinghouse. Just whatever you're most comfortable with. So I use that Novitas form to kind of hand type in what the claim would look like with those fields filled in. You'll notice that 17, you've got that 0 in front of the 1. Again, you have to be wary of that, making sure you're setting that up correctly. What I always recommend to, if you're new to rural health clinics and you're starting out, most of your systems give you kind of like a UB editable, or not editable, but like a preview mode. So if you are wanting to make sure that your fields are filled out correctly and you don't know how to like interpret those 837, now you can download some software that you can import an 837 and it'll put it in a readable format. which you may need to do if you're trying to troubleshoot like a loop and a segment issue. But if you're just trying to, generally speaking, figure out, do I have my, box 14 and 15 filled out correctly? I think I typed it in correctly in my software, but I want to make sure that it's going to show up. You should have a way that you can like preview a UB in your software, and I definitely recommend that, especially if you're just starting out, or if you are having to use a field that you're not accustomed to using, and you just want to make sure that it looks correctly. Do that before you file the claim off, because then if it rejects and then you sit on it, or it might take a minute and it's not fresh on your mind, you may not remember what exactly to look for. This is the bottom half of the claim, and I'm only including the fields that are generally required for your primary claim submissions. I'll have an example to show you an MSP claim filled out a little bit differently when we get to the Medicare secondary payer stuff. But you'll notice like little things too, like the 0001 up there in the top left. It should automatically appear there, but sometimes it's not, or it's just 2 zeros in front of the 1. The page 1 of 1 has to be there. The creation date is the date the claim was created. The totals have to be down there. You see your MPI. That 57 was that kind of legacy provider ID field that you may or may not need, probably won't need. If there's a secondary payer, you see TRICARE in this scenario is the secondary payer to Medicare, and their information appears as well on the claim when it goes out. And then the patient's information is, in this example, is their self. And so they've got your Medicare ID A, and then row B has the TRICARE ID. And then down, you'll see the diagnosis codes. I just threw some random codes in there for the example. And then you see that little 0 down there under the 66. That's the qualifier indicating these are ICD-10 codes. And for the provider, as I mentioned, you're probably just going to need the MPI and the doctor's name. Actually, if you end up putting in legacy information to the right of the MPI, it could cause a rejection. A lot of times the clearinghouses are, depending on how you're sending it, they will ignore those fields anyways. But so, the other part of this too is you have to, as you're thinking about this, you have to be thinking, okay, well, I'm not printing and mailing this to send it to Medicare. This is actually getting converted to an 837I, which is the electronic version of the claim form. And that's where it can get kind of tricky, because you're, a lot of times if you're looking at the way the 1500, or not the 1500, the UB is laid out, that looks differently, obviously, when it gets into the electronic format. But you need to be aware of that, especially if something looks one way on the printable form and then it doesn't show up the same way when you're trying to send it electronically. It could be something to do with the way the electronic claim is being pulled that may not match the same way the printable version is being pulled from your system. These are just, common, the CMS 1450, aka UB04, that ANSI, ASC, EXA, that's the, the name of the claim version. There's been different versions over the years. And I remember when I first started out in the early 2000s, there was like 4010. We had to get things updated for 5010. But there is a website. So if you want to learn all these loops and segments, so if some of the more technical folks in your office need to learn these things, there are helpful online tools that help you crosswalk those boxes that I mentioned to what loop and segment they are. So, and the reason this is important is if you do sometimes get a rejection from like a clearinghouse, for example, they may reference the loop and segment in the rejection and not the box. So you would need to know when you're reading the rejection, okay, it's going to say invalid, missing, required field, loop, 2010 AB. And so you're going to need to know, okay, what box does that correspond to? I still do that to this day because I'm more comfortable dealing with the UB boxes. So I say, what loop and segment, how does that correspond to the actual field on the UB? And it helps me kind of think my way through it when there is like a rejection related to like a missing field, an invalid field. So that is worth pointing out. There's a link again to all these. So if I reference something, this one is the Palmetto crosswalk, but they're probably going to be all the same. The different Macs, there may be differences, but most of your Macs are going to have something like this. It's going to help you crosswalk the printable version of a claim with all the boxes and fields to what the electronic equivalent is. So again, these are things too, like I would recommend that you're bookmarking these things, that you have them handy, so you're not having to like trying to research this if you're in a pinch. All right, this is where the real fun stuff starts. So Medicare secondary payer, we were joking about this earlier. It's just way more detail for Medicare secondary payer than you would ever imagine, and leave it to Medicare to make this very complicated. But at the same time, I get it. You know, they have a reason why they want to make sure that they're either the primary or the secondary payers. There's a lot of money involved. So some of the main resources I was referencing that I will point you out to is the first one. So it's really kind of easy to read for once. It's the MLN booklet, Medicare Secondary Payer, and it's up to date. This one, they keep it up to date on a regular basis. There's a lot of stuff in here that I'm not going to go over because, like Mark said, it could take a while. So things like conditional payments, what to do if the primary payer is not Medicare and it denies, but it's there, and you need to be aware of it and read it and know what's in there too. So that way, when you are running into problems with your Medicare secondary payers, because you will, this is a very good resource because they try to put it in more layman's terms, and there's a lot of resources within this one document that are linked as well. So depending on what you're looking for, what the issue is, that is a very good document that I definitely would recommend you bookmark and keep on hand. But some general terminology, Medicare secondary payer, it's a program where Medicare wants to make sure they identify scenarios where they are not the primary payer and some other entity. And it's not as common as most of the time Medicare is your primary payer, but there are scenarios where Medicare is not. And so this helps Medicare from making too many payments that are unnecessary. You know, if you just send them a claim this primary every time and they paid it, you know, that's what they're trying to guard from. So they're putting responsibility back on us to make sure that we're doing our best. So we're not just firing off everything to Medicare as primary and then waiting on them to bounce it back to us to tell us who the primary should be. What's crazy is you have to keep this MSP information on file for 10 years. So, and I know that was covered on previous installments of this same, but I wanted to point that out too. So the questionnaire is kind of what drives the process and helps you figure out, is Medicare secondary or primary? And so the Medicare secondary payer guideline, I have it linked here too. That one is a little bit harder to read, but again, that is kind of your Bible, if you will, going back to the actual legitimate regulation and what Medicare's rule is. So I am going to kind of toggle back and forth between this one is back in the booklet, and it basically says, hey, look, we've got to do this. $8.5 billion in 2018 alone is what we saved by having these provisions in place. We're not accidentally processing claims as a primary payer because we've identified there is another payer who should be paying primary to Medicare. So that is the purpose of this, but it is complicated in order to accomplish it. So what I do like about this booklet is it kind of walks you through the scenarios of when someone might be primary to Medicare. And this also comes from that, and it kind of goes through Part A versus Part B and what you need to do. So you got to gather the MSP through the questionnaire, figure out who to bill. And if you have to bill someone else prior to Medicare, you do that. And then you have to submit the Medicare secondary claim information on the Medicare claim in the proper way. And you see using those value codes, condition codes, and occurrence codes that I mentioned earlier that were not necessarily needed for when Medicare is the primary payer. And then of course you have to consider what loops and segments they are. So again, think back to the electronic crosswalk that I mentioned earlier. A lot of times your clearinghouse too will have helpful ways for you to manage your Medicare secondary payer fields too. And I know your practice management system will as well. So I screenshotted these. I was kind of surprised at how many different scenarios there were, but then when I actually read the questionnaire, all 12 pages of it, I said, okay, that makes sense. You have to basically, for every patient, and why the questionnaire is important, which we'll get to in a second, is trying to figure out, what the scenario is for today's visit. And then based on that scenario and the condition, who's primary? Is it Medicare? Is it COBRA? you know, black lung program, where am I in an auto accident or a workers' comp, and is that carrier, you know, responsible? So like here, so a lot of times you'll see, and I see this a lot too, you'll file a claim and Medicare is the primary payer, but you didn't organize your diagnosis codes correctly on the claim, and you use some sort of injury code in the primary spot. And you've probably seen this before. That will probably trigger some sort of denial because they're going to think, okay, this might be workers' comp because I've got some sort of injury related diagnosis code in the primary field. Same with auto accident. I won't go through all these, I'll spare you. So some things to point out that is in the actual Medicare secondary payer guideline, and this is leading up to the actual questionnaire, is you have to ask a series of admission questions that is required. And that generally speaking, you have to do it for every admission, outpatient encounter, or start of care. And there are exceptions to that rule, but you basically have to be checking it every time just to validate. You definitely have to do it on the initial, and then they said you really, if the patient is coming back in and it's been 90 days, you need to verify it again. And that's kind of the general rule of thumb. However, if you continue reading, if the MSP information collected from the hospital is no older than 90 days from the date of service, then that information may be used to bill Medicare. But this policy, however, will not be a valid defense if they decide that they need to recoup money later on. So they've had different recommended versions of this, and this is the most current one. That is a link there to it, the questions to ask. And if you read at the top, there's a very specific way you have to kind of go through it. They're like yes, no questions. Depending on the answer, if it's yes or no, you may be directed to a different section of the questionnaire. So what we recommend is that you analyze the questionnaire. You need to have this embedded in your software. Most software systems, if it's a hospital system, it's going to have it already probably built in. If it's an ambulatory system, you may have to build it there. So for rural health clinics, you may need to build something in that helps you ask these questions. What I would recommend is you try not to build like a 7 to 12 page version like Medicare has, but you use that to kind of guide your way to build something like this, which is, I think, something that Mark has actually, I copied this from a previous presentation. You want to build something like this to help you get the yes or no questions answered. And then depending on if there is a yes to one of those questions, that they're being directed to fill out the other portion of the questionnaire that gives you the information that you need. So if there is a yes and there's someone that turns out it's going to be prior, you have to capture that information on the questionnaire. And this is just an example. There are some, and what I would also recommend is there's some online tools. CGS has a great one, Medicare Secondary. It's basically a clickable version of what I would recommend you have built into your software. So if you want to see what that would look like, I would go to the CGS website. There's a link, and it will actually start you through the yes/no questions. And depending on where you click, it's going to give you the information that you need for either the MSP claim. See how this one here gives you the code there that would end up going on the MSP claim, or the actual questionnaire itself. So I should have probably put these in reverse order. But this is one, like if you're going to put the questionnaire together, the first question is about black lung benefit. Now, if I would hit yes there, the yellow bar would have come up and said, you need to bill the black lung program for this service. So, but if I hit no for Veterans Affairs, it went on to the next question. And if I went no all the way down, or if I hit yes, then it's going to give me the appropriate answer. So click on that link. It's the CGS link. Click through it in all the different versions. And that's basically that's your full MSP questionnaire, and it's a simple way to consider it. And you could use that tool if you wanted to. It's a nice tool. It's a standalone tool. Another thing to point out, this is from the booklet. There's the Benefits Coordination and Recovery Center. So they're the group that consolidates the activities, that they manage the reporting, and they keep track of who should be primary. Supply information on supplemental drug coverage. That slide on the left actually came from, and I would also recommend, it's a great resource, the CMS Medicare Secondary Payer Overview presentation. And it was just worth pointing out that this organization, Benefits Coordination and Recovery Center, if there is something awry with the patient's COB information, it needs to be corrected, it would be through them. And that it's aware of what this agency does and how this kind of addresses MSP. So I kind of put this on here for you to kind of be aware of. This one is a little bit much, but I liked it because on the left in particular, this is CGS, they give you kind of a diagram. So if you like these kind of diagrams, they have a really good one here that kind of gives you, it's similar to the clickable one, the yes, no, but this one has it all. This one kind of maps out all those yes, no questions that I showed you on the previous slides. If you wanted to see what the answers were, depending on whether you click yes or no, to each one of those questions on the questionnaire, this tells you what the next step would have been and leads you down the path. And then they also have a very nice Medicare secondary payer billing and adjustments tool that gives you those boxes that we talked about that are only maybe used if it is an MSP, and some of the ones that you might have to fill out special fields, so like boxes of value codes, for example, and things like that. That is handy. So here's one. We've got a claim where we billed an office visit for $168 to the primary, which was Blue Shield. I didn't mean to put Medicaid on there, but I typed this one in using testing information, but say it was like Blue Shield was the primary. They paid $32.26. So you will see that up there under the value code area in 39 with the MSP code, which is 43. It says disabled beneficiary under the age of 65. And the other common one is 12, working age beneficiary or spouse that has an employer group health plan. So you can see that those two fields are filled out. And then if you go down further, you'll see 54 and 55. So you have your prior payments and estimated amount due. Now these may not be, I'm thinking we filled this out correctly. Again, I hand typed this in to kind of give you an example of what the MSP information would look like on the claim. And there it is with the fields filled out. There are some others that you may need to use in other scenarios, but this is kind of like one of the more common ones. You also see that occurrence code up there in box 31. So the electronic component of this is similar to like when I wrapped up the UB04 fields. You've got to know what the loops and segments are for the claim, because a lot of times if you are stuck dealing with a rejection, an MSP claim that's not getting through the clearinghouse, you're having to interpret loop and segment information in order to figure out which field you need to troubleshoot. So that is Palmetto's guide down there at the bottom. Your different Macs are going to have their guides too. You are going to have to learn some of this to try to figure out. A lot of it has to do with those additional fields, what the primary paid, and all that has to be filled out just right, or the claim will not process. And there's a lot of resources here, and I put, if it was relevant to the slide itself, I put the link at the bottom of the slide. But here is kind of a summary of all of it here, including the link to the questionnaire, the MLN booklet that I mentioned, some sample questionnaires are here, again, if you want to do that. So then there's some videos actually that are very helpful. So in this one here that I put at the bottom is an example. There was actually several, but Noridian did a whole series of MSP. There's that video plus several others they did just last year. So they're pretty up to date, and they go through all the MSP. There's actually, this is a 12-minute video here on the MSP compliance and payer types, but then they also have them, they have like 3 or 4 more that all kind of tie together through the MSP process. So I would definitely recommend that, that you check out those. And this is basically my last slide. I meant to put like a thank you slide with my contact information in it, on it. But yeah, so I hope I didn't bore you guys to death. If you guys have questions, I'll try my best. I won't be able to probably answer all of them, but maybe between us on the call, we'll be able to answer them the best that we can.
Okay. Well, Doug, thank you very much. I tell you what, I think I'm missing a few loops and segments after hearing about how complex everything is. So, Danny, you got some questions for us to attempt to answer?
You're funny. We've got a lot of questions.
Oh, no.
All righty, I'll just start at the top. Can you go over Medicare, primary mental health, and medical health on the same claim? Do we have to have two separate claims? I'm having trouble showing the correct rendering provider. My system is only doing one rendering MPI. Is it appropriate to do one claim for each service?
I think so. And let's see. I actually have the Medicare claims processing manual pulled up. For the MPI form, I think what I read, and Helen, if you're on, can you talk? Because I think you're on. I think they said whoever does the majority of the services, you use that person's MPI. I don't know how you go about figuring that out. But I did read that in the processing manual. And so if you look at section 20.1, you have per visit payment and exceptions under the AIR. It talks about patient having a medical visit and a mental health visit on the same day.
Yeah.
And I'm trying to read here
if
it's allowed on the same day or not. Feel free to chime in.
Okay, yeah. Yeah, I was gonna tell you, Doug, I did make, Helen is a panelist, so now she can talk. Janet Linton, who actually did the 5010 presentation many years ago, probably 10 years ago, that I basically just copied and pasted and sent to everybody for many, many years, that had all of these field locators in it. I made her a panelist too, Janet. So if you want to pitch in, you can do that. And then of course Charles James from North American, I made you a panelist as well, Charles. So if you want to pitch in on any of these questions, please feel free to. Helen, let's see if Helen's line is open. She can help us with this one. Maybe she may have a. I'm not sure. Okay, it says something about.
She's on her phone, so I don't know unless she enters.
This says here, so under actually 60-1, it says encounters with more than one health professional and multiple encounters with the same health professionals that take place on the same day at a single location generally constitute a single visit.
Yeah.
Well, I'm sorry. Hey, folks, this is Charles. I am here. It was the original question. Are these two visits?
I think she was asking if she had to separate into two different claims.
Or like a medical and a mental health visit on the same day.
Yeah, because she's having trouble showing the rendering provider. I assume they're obviously two different ones. And so she's only able to input one rendering provider MPI. So she wasn't sure if she needed to split it into two claims.
Interesting. You know, so I am doing, and I have an example of this, and this is an occasion on multiple encounters. Behavioral health clinical visit on the same day should be two encounters. It's one of the few occasions where we have two CG modifiers on the same claim. But also interestingly, I don't know if I should say this out loud, when I went to get examples, we were splitting them into two different claims. So ultimately to me, I said, okay, well, kind of no harm, no foul on that one. So they should pay on the same claim, but indeed some of this is going to be software related on how you can, you know, whether or not you can even get on the same claim. So pardon me. It should be two encounters.
Hey, Charles, I have found that out to be true as well. For many years, people have, when I would do the seminars, they would come in and say, well, we tried to do that mental health and E&M code on the same claim, and it would not process. If we sent them in as two different claims, it worked just fine. So I've heard that for probably 10 years or so. Okay, next question, Danny.
Vanessa asked, how do you get secondaries to process negative deductibles? I think she means like negative reimbursement.
Yeah. My inclination is you don't. I don't think they really have anything to do with that, would they?
Yeah, were you talking about the negative deductible from the recoups? But that would be when Medicare's primary, right?
Yeah. Yeah, I don't think the secondary payer is going to pay because because Medicare is primary withheld. I mean, that very weird negative reimbursement that you get at the beginning of the year is a very, very strange thing. And so I know, Charles, I'm going to talk a little bit about that on our advanced session next week, because I keep getting a ton of questions about that.
So maybe the question is like, how do you cross that over to the secondary when Medicare does that recoup when they're the primary and they applied the entire visit to the deductible?
Yeah. Yeah. Do you know how to do that?
Well, we talked about those fields. So when you're doing in a typical scenario, when you're filing, a lot of times Medicare crosses it over for you, right? So it's not, you don't have to do anything. The only time you really should have to mess with this is if for some reason there is a secondary payer, Medicare does not have them on file, and you are having to physically send them the claim because Medicare did not cross it over for you. And that's when, you have to, when you're looking at the fields, you have to make sure they're matching. So it's going to be a little weird because you may have like a negative amount, in your adjustment. If I had time, I'd have to pull up a live claim and I could show you the adjustments and how that they are filled out on the secondary claim, and we could probably show you that.
I think to go further into it, because I think Vanessa, we were talking on Facebook too, is she commented, I can't tell you how many insurance return those claims to us denied for missing or invalid primary EOBs. So they're not even accepting the remit.
Oh, really? Even with is that when we were sending the claim directly, or and it's not a crossover?
I couldn't tell. I'm just going off of her little comment, so I'm not 100% sure.
Yeah, because if you send the claim electronically, they usually don't need the EOB.
She said yes, crossover. I'm sorry.
Yeah.
Okay, well, that may be a subject for the advanced session. Doug, if you got a little bit of time on Tuesday, we'll spend a little bit of time on that. These questions are really hard, and that's one thing. Again, this Medicare secondary piece is probably the hardest part of RHC billing that I'm familiar with. So, Danny, you got another question?
Yes, sir. How would you bill non-COVID related telehealth Medicare G2025 to commercial secondary?
These are good ones. I don't know the answer to that one. I don't know if anybody else does.
Hey, it's Charles. I think you'd have to change the code back to a regular CPT code, because that's really a Medicare only code.
Yeah.
I don't think any commercial payer is going to recognize. So I think one of the tough things that we have trouble getting our heads around as billers in the RHC world is that, yes, sometimes you got to change the codes from what's required as an RHC pay, on our Medicare claim to our secondaries. So there does so back to Doug's comment on DDE and having online access, that's why it's just easier to deal with some of the claims there. But on a G2025, I don't see a commercial payer recognizing that on a secondary claim.
Yeah, it reminds me of the T codes that sometimes you have to use for the Medicaid plans, and sometimes you have to change those up if there's another payer.
Precisely, exactly.
Okay, let's see. I'm going to pick up this question here from Jennifer. Do you have to put a 0 in front of the numbers in box 14 and 15? And
I don't think so. I think it was 17 that needed it.
Okay. And then the next question is, we have Azalea and we can't get the 0 indicator to fall into 66. I guess that's field locator 66 maybe.
Which field is 66?
66,
Or which one is that one? Let's see here.
Not.
Of course, it's not on the screenshot.
Yeah, 66.
Oh. Oh, so that's the qualifier for the 0. That should automatically happen. I don't know why that would not be there. I would have to reach out to support, because that should be something that when your accounts are configured, that there's probably a configuration that has to be checked that says, are these IC9 or 10? Maybe it wasn't checked when the database was set up. But it should just be a one-time thing. You flip that on, that zero should always show up.
Okay, Danny, you got a couple more, and then we will we'll close out here right at 1 o'clock. So give us a couple more, and then we'll close out.
Yeah, I just, Louise actually had a note. She said, note for others in case they are having Medicare secondary payer denials on Medicare primary claims or an RTP denial. Check your system eligibility process. We do not use Azalea, sad face, and our real-time eligibility changes the MSP field based on information in CWF. However, it doesn't mean this visit is related to the CWF reason. I have to remember to manually change this back or the claim is RTP, just an FYI. So I was just sharing that. Are nursing home patients an exception to the Medicare secondary payment questionnaire?
I think it's for the hospital admissions and outpatient.
Yeah, I think that we always get a little bit of flack on this MSP questionnaire, but my understanding, the way I've always understood it, I know in Missouri several years ago too, they had all sorts of audits on those, and what we got from those audits was you were supposed to be asking those questions every time Mrs. Jones came in. You needed to ask those 8 questions there, that 12-page questionnaire. And a lot of people say, well, it's every 90 days. I'm like, the way when they did those audits, they were like, it had to be every single time you came in now. And a lot of people will have in their system a little check mark where you can go in the electronic system where you can just check that you asked Mrs. Jones if anything changed since the last time you came here, or if Mrs. Jones comes in and she's got a broken arm, you really do need to do an MSP form because you need to find out if she fell at Walmart or she had a car wreck or whatever, that there's somebody else out there to pay for that. Charles, is that your understanding of the MSP rules, or am I overstating it?
No, that's exactly it. And the reason the 90-day thing doesn't work is because our rural health clinic encounters are not recurring services. They're not exactly the same every time. So I think, yeah, if most of our rural health clinics were audited on their MSP questionnaires, there'd be a high failure rate. And indeed, every time the patient comes in, there's supposed to be documentation that you've asked the quote unquote MSP questions. Yep.
All right, Danny, we're 2 minutes over time here, so I know people got to get, lunch break is over and time to go work. Thank you guys for what you guys are doing. Stay safe out there. Doug, thank you so much for this.
Thanks for having us. I appreciate it.
Yes,
Thanks
thank
for
you.
coming on Friday.
For what you guys do. Okay, everybody, thank you. Thank you to the panelists. We'll talk to you later.